being undiagnosed.
So that's even like blunt force, like a bruise?
Anything. Kitchen accident. Nothing. She'll bleed out. Almost did. A couple of times. All right, so she found this out 2 days after her husband committed suicide. So think of the psychological impact of that. Double, triple whammy. So she found that out, and the shock of her husband's death and this, neither of which resulted in a referral to grief, medical, or crisis counseling by either a doctor or healthcare worker or police. All right, major life trauma. Right? So the medical community diagnosed that. Police came to tell her about suicide of her husband because, you know, where it was found, et cetera, et cetera. What should have happened, ideally, by any one of those folks? Right? And let's say that she lives in this community. I mean, because you also have to think about, you know, what are the resources in the community you have for the people that you're encountering?
Well, don't they usually ask at least if you live alone or send you home with somebody?
There is that, yes. Mm-hmm. So none of that happened here. So she binged on alcohol, drove herself home, hit a pedestrian who lived, and was sentenced to 4 years of prison. This is her first offense in her life. And treatment in prison consisted of an offer of meds. Basically, oh, tough luck. That was it. So, while in prison, she was allowed to begin doing Native American sweat lodge ceremonies, which began an exploration of native-based recovery technologies. She was basically on and off the res. That's where injectable drug use occurred. But obviously part of that experience was not really participating in any Native American spirituality or religion or anything like that.
Was she still using when her husband died?
No. She got him clean.
So how could she be in prison if she couldn't be injured at all?
Yeah. For a first offense. Yeah. How could she be? And, you know, again, we have a legal system. So part of, well, right, there are other people around where this happened that have hit people and killed people that didn't get prison sentences. Identical circumstances. Can you guess why the difference in sentence?
Race.
It is there. It is there, right? So, okay, you hit somebody, broken leg, thankfully, but you get 4 years of prison. Somebody who hit somebody and kills somebody may or may not get prison. And it's not a function of the lawyer, necessarily. All right? So, in any case, fortunately in this state, for her, I mean, this is what she credits for as some of her recovery, she essentially was able to hear more about Native American spirituality, and that helped assisted in her recovery. But she had to get it in prison. Now, not that that's the only place that it's available, but it was available at that point. So, because of her medical conditions, she has to be aware of her viral status as well as being able to grieve and heal. I should actually correct that, but grieve and heal properly, which affects her immune status. Because of, if you heard of psychoneuroimmunology, You know, somebody say, one of your classmates said, this is really heavier than last term. Yeah. For pros, you gotta know this stuff. Psycho, neuro, immunology. Basically what that means is your psychological and emotional state affect how your immune system functions. If you feel better emotionally, your immune system functions beautifully. If you get depressed, your immune system tanks as well. And what immune system she has basically has to get, I mean, she's dealing with a lot of stuff, right? So that meant for her, well, that means for her, because she's still around. Eating right, exercising, but not injuring herself. Yeah. Lots of walks in nature, things of that nature. But the relatively new field that studies that, psychoneuroimmunology. Right, so processing grief, anger, shame without relapsing on anniversary dates and triggers. And we should know, let her know, right, that at minimum, you can be grieving for easily 5 years after a death, depending on how close you are. That's normal. Just say that that's normal. Why can't I live? You have to do what you have to do.
But after 6 months, you're diagnosed.
Yeah. Right. Notice a dichotomy there, huh? I think the diagnosis could come sooner, too, but so we want them to look out for anniversary dates or other environmental triggers in memory. If there was a traumatic experience, there'll probably be PTSD-like flashbacks of the event. Stuff could happen, come up in dreams that are vivid enough that you'd have to process them as real events, too. Lots of different ways of working with this. All right, so she does generic 12-step AA meetings, powwows, sweats, is considering TP meetings, that is peyote meetings, as well as exercises, and she also paints. So often one of the things I do with clients is, what is your art? And they go, what is your art? Are you, do you draw? Do you write? Do you paint? Well, I used to as a kid. Well, I want you to be able to draw your anger, or draw your grief, or break down specific emotions so we can talk about them, and you can draw them out. Where are you feeling them in your body? All those different things. So,
Was she addicted to alcohol?
well, yes, she met the diagnostic criteria, but you would meet the diagnostic criteria for that one event if you binge drank and broke the law. Because the way DSM is written, you have to have tolerance and withdrawal for a drug, and it has to negatively affect 3 life areas, including legal. So she met the diagnostic criteria right then by binge drinking, drunk driving, causing injury.
They put her in an AA meeting? Or?
No, they put her in prison. And she basically did AA meetings to the degree they existed in prison. This is her recovery program now that she's out. And no longer on paper. Parole.
Did she do any of that when she stopped the other stuff?
No, on the res, when she was shooting up as a kid, None of that, right? So then that's where she got infected. She grew, aged out of that. Sometimes that happens. Or just moved away from the res or drug-using friends. Didn't touch a drop of alcohol because she saw lots of alcoholics around her. And therefore, when the strain got too big, where there was that precipitating incident, she used the coping skill of drinking. Probably drank less than the people around her, but if you don't know how to modify your behavior, and then that's one of the things with psychoactive drugs. So as an example, this is a little early, but it's topical. So the concept of, you've heard people talk about gateway drugs. And basically what this means, it's not a fuzzy concept, but there's a lot of latitude, and I'll show you how this works. So in the early conception from 20, 30 years ago, people use drugs in particular order. And this order could vary. So, as an example, because alcohol and tobacco, they're age-controlled drugs. That means you have to be a certain age to do them and acquire them, right? But they're around in a household, and you can acquire them if they decide not to card you, or you do shoulder taps and ask an adult to buy for you, or go to your parents' liquor cabinet, or steal a beer or whatever. So alcohol, tobacco, and marijuana were considered gateway drugs. So here's how it worked. Alcohol conditions you to the idea that a substance outside of your body can change your consciousness. Because you can't tell me anybody's drinking Bud Light for flavor. Or Ice House, or PBR. I'm sorry. Flavor, get real. Well, you're getting it, get sloshed. Right? So alcohol conditions you to the idea that a substance outside of yourself can change your consciousness. Tobacco, while there is a slight change of consciousness, what it does, it conditions the lungs for smoking. But these are age-controlled drugs, quasi-legal. How many Americans actually wait till 21 to drink? How many Americans actually wait till 18 to smoke? Right. Okay, but there's a line that people, try not to cross initially, right? It is a barrier. So, and talking about where this concept came from before marijuana was, before it became a medical marijuana state. So now, marijuana, tobacco, and alcohol are considered gateway drugs because marijuana, in order to acquire marijuana, you have to break the law. You have to cross a legal line and be willing to break the law. However risky that is, which, around here, how risky is that? Well, it used to be more risky. In New York, it's way more risky. Texas, brother spent 40 years in prison for possession of 2 joints. So,
well, and how much does that risk contribute to the desire?
Indeed, right. Right. Especially when you're a teenager and you want to do a rebellion thing, right? So conditions the lungs for smoking, and then marijuana, once the lungs are conditioned for smoking, then conditions you to the idea that a substance outside of yourself can change your consciousness that you can smoke. So in that sense, they're gateway drugs. And then even though marijuana dealers and heroin dealers are not always the same person, or rarely the same person, once you cross the line into the underground economy, then you can access other drugs, the theory goes, right? So with alcohol, you learn, there's a learning curve with all drugs. You learn by having it being role modeled how to use the drug, by observing and also personal experience. once you drive the porcelain bus, that's, from drinking too much, that's, can be aversive for people. It was aversive for me, but not for my alcoholic friends. Right? With her, she aged out of or changed her environment, so no longer hang around with injectable drug users, avoided alcohol, but as soon as things got too much, she drank and didn't have the experience to say when to stop. And at the time, she's a grown woman, so I can do this.
I've never heard of someone using meth and heroin as their drugs of choice. Is that common?
Yeah.
I mean, kind of, maybe not.
You mean together
but,
or what?
Well, I've heard, what speak, that's coke and heroin.
Yeah.
I've heard of that. But,
right.
They either like the down or the heroin, or maybe they'll go through a phase of that, and then they'll go through a phase of something else, but not just kind of you know what I mean?
Yeah. So as an example, all right, when we started looking at the whole issue of polydrug use, that poly meaning many, and people using many drugs together to achieve a certain effect. So one of the common drug combinations, it's called the speedball. One of the names for speedball, so coke and heroin, basically the coke cuts the down of the heroin cuts the edge off the coke. All right? There was another term, and one of the challenges with there's online you can find dictionaries and lists of drug slang terms that change. It's useful to know them, especially when clients bring them up, because you don't want to look like a dweeb, right? So in some places, a parachute is meth and heroin at the same time. And it's the same principle. The meth cuts the down of the heroin cuts the edge off the meth, and instead of the spike that you get from shooting cocaine, because the drug action is longer on meth, you float down slowly, hence the name parachute. So you do find it.
So you're not nodding.
No, you're not nodding because the meth's there, and I mean basically it's when you do a combination, and this is why it was kind of dangerous, Four Loko, Red Bull, all right? So a long time ago, 40 years ago, we knew, okay, you don't sober up a drunk person by giving them coffee. The coffee and the alcohol are working on two different parts of the brain. It just simply means you'll be awake for the accident. Okay? So now to sell that combination, that's irresponsible, but I ain't no Marxist, but capitalism, there's parts of capitalism that's amoral. They don't care about what your health is. They'll string you out. Four Loko, Red Bull and whatever, no. You'll be awake for the accident. It's not making you less drunk. So we're working on different parts of the brain.
So that's what she was doing, she was using them together?
Yeah.
That combination is sold in every day.
Yeah, right.
It's what?
Which combination?
The meth and the heroin.
Yeah.
There's enough heroin in there to keep you up.
Right.
You keep buying it.
Right.
Unsuspected.
Yeah.
You know.
Right.
Oh.
Yeah. Yeah, that's not unheard of. And that's one of the pieces in terms about, that's why I wish we had, kind of in the Haight-Ashbury, in the 60s and 70s, since I was around then, right? PharmChem basically did testing of street samples, and they would publish them in the local underground newspaper. Say, okay, here's a sample of LSD, barrel LSD, paper LSD, contain actual LSD in this amount, or was phencyclidine. Here's some marijuana, or actually supergrass, which is actually partially sprayed with PCP. They print that, or here's some LSD that actually has methamphetamine in it. And they would publish that, and the law enforcement community said, oh, you're just advertising for the drug dealers. And they're saying, no, we're basically saying, you're not stopping these people from using. They should at least know what they're using, because unlike aspirin, there's no quality control in the underground economy. You know, like I think I had told you before, but in case I hadn't, because I misremember stuff, one of the early heroin epidemics at LCC came when the dealers were selling our students black tar heroin and saying that it was opium. And they believed them. Oh, it's just opium, right? Because if they told them it was heroin, they probably wouldn't have done it. But we did such a great job of scaring people away from needles, they figured smoking heroin would be not as addicting as shooting it, or not as bad. I'm smoking. Well, no, that's as bad or worse in terms of the science. And we'll get into all that. But, right, so it's not surprising that meth and heroin are being sold together, because that would make sense, given what used to be a separate practice would evolve to standard practice. When we used to warn people away from drinking alcohol and thinking you're sobering up from coffee, they would come up with, let's put them together, because you want to keep partying, don't you? Yeah. All right, she also keeps a dream journal and has written recovery stories based on her dream experiences. She's also developed what she refers to as a relationship with her death. She says it helps her focus in case she faces death imminently. So it's a way of, so all this actually that we're talking about is part of many indigenous Native American spirituality constructs, religion, if you will. Some of this can be adapted. So some of this has been in Western psychology as well, and yeah, so that's one of the reasons I use Carmen as an example. So not just the story, but what you can also suggest as part of therapy, if they're into it. Tony Soprano. Haha, not his real name, but everything else is true. 30-something, Italian-American, Dewey client, dual diagnosis, anxiety disorder, alcohol abuser. Mr. Soprano drinks socially and as a coping skill. And he freely admitted that. And is from a family of drinkers. Wine, all that kind of stuff, stereotypical, Italian family, right? Grew up with bottles of wine, with meals finished by mixed drinks, which his family used to self-medicate social anxiety, which they were talking about living in a big city, legal occupation, et cetera, not the stereotypical mafiosos or whatever. Don't go there, right? But this was him saying, so if a client is telling me that up front, then that means that he's had some experience with somebody in the mental health field to get that diagnosis, right? Okay. Self-medicate social anxiety. So he went to see a shrink and a psychologist for panic attacks, and they prescribed an array of pharmaceuticals, including Xanax, Klonopin, Cymbalta, and Abilify. Yeah.
There are psychiatrists that don't even know that Xanax and Klonopin are abused.
Yeah.
Maybe the other two.
No, look. What you're bringing up is we're not qualified to diagnose as drug counselors, right? But our training requires that we know as much or more than the people prescribing the meds. Ironically. but we can't prescribe meds or diagnose. So a lot of times these folks, a shrink and a psychologist. So a shrink, a psychiatrist is a medical doctor, right? Some psychologists also have DEA numbers and can prescribe meds too. They may or may not be talking to each other. Okay? Even if the pharmacy is dispensing, so you'll get the standard, when you get a new medication, the drug education talk from the pharmacist. Don't mix this with alcohol, right? So Xanax, Klonopin, Cymbalta, and Abilify. So, both mental health professionals as well as the dispensing pharmacist emphasize Tony should not mix alcohol with his meds. He continued to drink, which led, of course, to his doing. But probably had a problem before this. But it was accelerated by following doctor's orders, but ignoring the instructions not to mix those meds with alcohol. Okay? And he's referred to me to talk to someone. So, for example, Cymbalta. This is from Wikipedia, so you can also use the PDR. Antidepressant in a group of drugs called selective serotonin and norepinephrine reuptake inhibitors. Cymbalta works by restoring the balance. Now, this is drug company propaganda. Understand what this is. Restoring the balance of certain natural substances in the brain, serotonin and norepinephrine, which helps improve certain mood problems. Cymbalta is used to treat major depressive disorder and general anxiety. Disorder is also used to treat chronic pain disorder called fibromyalgia and treat pain caused by nerve damage in people with diabetes, diabetic neuropathy. So, for example, the top 10 drug companies make 50% of all profits in the Fortune 500. So when a drug company commercial talks about their drug correcting an imbalance, first of all, there has never been a normal balance established by science, ever. When people are insane, you measure, do blood work, they have a normal balance of neurotransmitters. Okay? So, what are they talking about? They're using a scientific finding, and the theory of how this drug works is that it increases the amount of these particular neurotransmitters as if we're correcting an imbalance. Well, we never established what a healthy balance is to begin with. So yes, you are modifying the neurochemicals, but correcting an imbalance is a way to sell the drug. Ask your doctor if Cymbalta is right for you. Just saying. So that's just one of the meds that he's taken, been prescribed. So the question is not often asked, how did you get unbalanced anyway? What put you out of balance, as long as we're talking about balance, even though we've never established what that balance is? How long will the drug keep you in balance, and will not taking the drug put you out of balance? What can you do to get back in balance without depending on the drug, if that's possible? But what normally happens is this. So we're not even talking about balance. They're just saying we're correcting a chemical imbalance where we've never established a balance. So most consumers, of course, don't know that. They trust the MDs. So the client is an adult with a quote-unquote normal, culturally reinforced use of alcohol. Now prescribe 4 pharmaceuticals that don't react well with alcohol. Each one of them does not. The physician and the pharmacist said these meds should be taken with alcohol. They do it anyway. And they usually do it as well, knowing that probably it's going to go in one ear and out the other. But they've done their due diligence. Okay, so there's lots of reinforcement about not doing this. So he might not meet the diagnostic criteria for an alcohol problem, which would be the only reason they medically can tell him to stop. Right? Because if he was just drinking wine with his family, not going out and having a crash, where's the problem? What if the family considers drinking a bottle of wine per person normal behavior? Now we've heard, I've told you stories, people thinking that drinking a whole fifth of vodka by themselves in the course of an evening is normal behavior. People drinking cases of beer as normal behavior. Not medically advised, but the doctor can't tell you to do something without evidence. If there's no problem, they may say cut back on drinking, moderate your drinking, but you might not necessarily do that. So, think he's going to stop. One of those meds is physically addictive in less than a week of prescribed use. Xanax, in particular. But if you're under a doctor's care, you are not technically an addict from the point of view of the law. You are an addict or seeker when you try to acquire controlled substances outside of a prescription without a medical condition. Right? So, see there's some contradictions here or things that we got to wrestle with. Right? This is the contradictions that we deal with in the field.
Well, isn't it a contradiction to say if you're prescribed certain medicines, your body becomes dependent on them, so you're just as well an addict as you are dependent. You might not be going somewhere to seek the medication, but there's no difference.
Isn't it? It's dependent on if you keep seeking higher and higher dosages.
Correct.
Well,
right.
that's what I'm saying.
There's that too.
Even if you're not seeking, though, you're still exactly the same.
Yes. So here's the challenge, right? These substances, okay, you can become physically addicted to them. As long as you're under a doctor's care, the doctor is monitoring your use. As long as you take the drug at the prescribed rate, they might prescribe more. But as long as you're basically under a doctor's care, in the eyes of the law, you're not an addict. You do have to watch whether don't take your Vicodins and drive home. I was told after my procedure, right? The doctor was very, oh yeah, 10 Vicodin. Oh, I just wanted 2 Percocet for the evening. No, 10 Vicodin. I'll see you at 10. Okay, whatever.
Or OxyContin for a back pain.
Yeah, right.
Which is the same as Percocet, right?
No, it's strong. Oxy is basically pharmaceutical heroin.
So if you wanted to get more, because I know someone who was on Adderall and just had one doctor's appointment said, I can't focus, can I get,
right,
25s instead of 12s?
Mm-hmm.
Next meeting, he had 25s, and so I don't know. It's just ridiculous how they can just make one appointment.
The docs are trained. I mean, we deal with this in our student health clinic, too, right? Is it real that you can't focus? Well, we're trained to think, okay, the patient is reporting these symptoms. We have to respond to the symptoms. Unless we've got evidence that you're a seeker, we have to prescribe. That's not just here, that's anywhere. That's the medical protocol. Right? So in the absence of evidence to the contrary, we're going to assume that you're legit. Right?
But they don't even ask questions like, why are you watching TV while you're trying to focus?
Yeah.
What is the environment?
Yeah, right. Yeah, they're right. But that's not necessarily part of their training. Okay, the part of the training is, okay, this medical condition can be dealt with quickly and efficiently by this set of meds.
Would he need another appointment with a psychologist or shrink in order to get another refill?
Sure, or they just re-up, that's all, at the pharmacy. Pharmacy calls, yeah, renew the prescription, sure, go ahead. Or see us before you do that.
Oregon is trying making laws or like a database where they're trying to make this back happen.
Yeah.
And your insurance, if they're using insurance, it's
Right.
harder.
Right. But there's lots of drugs that are physically addictive to deal with pain, or Xanax, or whatever, right? They are. And part of the education that we do when there's a problem, when a problem develops, is, okay, don't go cold turkey from this, it can kill you, Xanax in particular. Just like alcohol works. Well, when we get into pharmacology, we'll talk about that. Cross tolerance and all that stuff. So yeah. And so, for example, if you have a surgical procedure where the recovery is long and painful, they'll script you with Vicodins, Oxys, whatever it is you need, and then if you express concerns about, well, will I become addicted because I've heard this stuff is addicting, and the docs will say, don't worry about that, we'll give you another pill to wean you off. Well, pills, you know, some people react, pills, no, maybe I don't want to do that. All right, so self-medication again. So once your script runs out, you can become a seeker and try and continue your addiction rather than go through withdrawals. So, for example, the dual diagnosis protocol. So, oh well, he's hooked on Xanax after a week or two. We don't say he's addicted because it's prescribed, but he can't go cold turkey. Abrupt discontinuance, this is language. Abrupt discontinuance is taken directly from the physician's desk reference, which is where, in coded medical language, what it says is doctor prescribed use can develop physical dependence. Physical dependence means addiction. So that's in the physician's desk reference about Xanax. And it says physical dependence has been documented in less than 2 weeks of use, a week to 10 days of use. And it says avoid abrupt discontinuance, that is going cold turkey, because you're going to risk withdrawal seizures. Withdrawal seizures basically mean it can kill you because you're in seizures and you can't breathe, and that's what kills you, by going cold turkey from the drug. So what they tell you to do is titrate. Step down a little at a time. So, but he's dually diagnosed. He's physically addicted to the drugs. Some of them are prescribed, and he's physically addicted to alcohol. So when he's reporting, I need these drugs to basically avoid panic attacks, what he's not thinking about, because he's not a drug counselor, is, you know, your panic attacks might be withdrawal from the alcohol. Maybe you've been drinking too much, you know, and, you know, if you don't drink your bottle of whatever your tolerance is up to every day, and you miss a day, you start having what feels like anxiety. That could be alcohol withdrawal. But he doesn't think like that because culturally he's been taught, oh, well, this is part of our lifestyle. And the shrink may or may not say that, unless they're actually in addiction medicine. So now he's dual diagnosis, or will be shortly. So addicted plus mental illness. So, yes, the meds are addicting, but he's taking them under a doctor's care, so it's only considered addiction if you do it to yourself and endanger your health, which he's endangering his health, so now he gets referred to me and I'm saying, okay, yes, you have this mental illness, these mental conditions, taking meds for those, so the protocol is to say, I can't argue you off your meds, but I can say you need to stop drinking on top of your meds. Okay? So he needs, what he optimally needs is skill building independent of the pharmaceuticals and other self-medications that he's doing. So, since the medical protocol is often not what is in the client's best interest, but in the interest of other elements of society, meaning we need your behavior controlled. If you can't control it, we need you to remain profitable to someone, so we'll drug you. This definitely happens in certain populations, like the developmental disabilities as well. We just put you in a chemical straitjacket. Or once we started closing beds at the psych hospitals and releasing them to group homes in the community, as long as you remain medicated, you're not a danger to self or others. As long as they stay on their meds, right? And that's the idea. So, pills are not skills. Okay? So, dual diagnosis clients, of course, need to abstain from non-prescribed drug use. In Tony's case, this means alcohol on top of the meds. So, in his best interest, he needs to develop the coping skills that the meds are substituting for, if at all possible, then wean himself off the meds under medical supervision. Probably not going to happen. But you suggest that anyway, as an eventual thing. Do not, under any circumstances, go cold turkey. I mean, there are people that do it from oxys, but they're rare. My hat's off to them. So, he'll find that his tolerance for alcohol has grown, both as a result of drinking on top of his meds and continued med use without skill building, if his stress increases. So, part of what we're trying to do is reframe the stress. All right, we're getting you off the alcohol because it's growing your tolerance on top of your other meds. So, how do we get you to deal with your panic attacks and your anxiety? Through talk therapy, basically. Because he's taking those meds for panic attacks, right? So, no drinking on top of meds, skill building on top of the stabilizing meds. Can't argue them off their meds. If they withdraw, it should be under medical supervision after skill building has taken place. So, for example, even though, I don't know how many of you have been subject to panic attacks, but dealing with people who have them, they feel that they're literally indescribable how bad it feels. So, panic is extreme unreasoning fear. Even though logically there's not an actual reason to be afraid because there's no actual immediate danger, they feel like there is, and the feeling is in their body and as in their mind. So, for example, with PTSD or past trauma being triggered or re-stimulated, that could be a source of the panic. Living in a stressful environment long enough where you stop noticing that it's a stressful environment, it becomes normal to you, that could be part of it. And the panic could be a result of body sensations being interpreted as fear, when there is no danger. And so you think about, where is the fear being held in the body? What's the sensation in the sensorium? And how is it being interpreted? Sensorium. What that is your sense in your body, how your body feels. So, for example, you're on the edge of getting a cold. Where do you feel that? My glands start going off, like throbbing, stuffy nose, beginnings of the cough, sore throat, right? The sensorium is your total sense experience within your body. Now, PTSD, just like there is when you have a fine motor skill like playing a guitar or cooking or something like that, what is called muscle memory, I mean, it's not like you've got brains in each of your fingers, but you've been doing something so long that it's almost like there is a brain within your fingers. Same thing with trauma. Gets stored in different parts of your body and can be re-stimulated based on what you see or experience, anniversary dates, any number of things. And you can feel, like, where do you feel anger? Oh, I feel upset in my stomach. I have an upset stomach. You know, I have chest pains, or, you know, my neck gets tight. Gosh. Trauma, emotions get stored in your body. So panic disorders could be coming from any one of those places. So we look at developing inner balance. What mind-body discipline will assist the client? What media do they consume? What's in their environment? Who or what are the successful role models or patterns for their particular circumstance? Is there a deeper level of sanity that they can be restored to? So, for example, give a simple meditation to people. So a primary alcohol client to stop using alcohol and don't dodge into using pot. Very common. People give up one thing, shift into another. Which, of course, he stopped using alcohol and began using pot. Well, I told you not to, so is that oppositional? Whatever. It's predictable. Don't guilt trip them, just, okay.
Well, it doesn't even have to go from alcohol or drugs either, because
Right.
I lost my best friend 2 years ago. She had a bypass surgery for weight loss, and she went to alcohol because she never dealt with the reason
Right.
that she gained weight to begin with.
Right. Right. Yes. Exactly. So, in terms of your consciousness, the effect is more subtle in terms of pot. So, yeah, pot could be less harmful than alcohol in the sense that, you know, it's hard to overdose on pot if you can even think of overdosing on it. Maybe eating a kilo at once could kill you. Anyway. 5 minutes they're about to tell me, I'm sure. All right, so in terms of your consciousness, the effect is more subtle, which he noticed when he stopped drinking and did the 11-minute meditation. He experienced a benefit when he stopped drinking, but he got bored with the 11-minute meditation and started smoking pot. Then he noticed that his meditation wasn't as powerful after he started smoking the pot.
So he smoked more.
Could, yeah, right, did initially, right? So this is a process, it's a continuum, right? We, you know, in this particular setting, you know, there'd be something happening different in treatment, right? But in this setting, because it's not technically treatment, basically I have to go along with what they're doing, and if they're not visibly stoned, et cetera, okay? We're working with them probably a little less rigorously. So the whole boredom piece, you know, I basically showed him this graphic of this koan. A man sitting on a rock contemplates eternity. The stone grumbles. So if you were actually sitting on a rock and you could sit on it long enough to hear a stone grumble, that's a pretty major accomplishment. Stones are not going to notice people. Something around 1 million years. Humans are like mayflies compared to that. So a Christian mystic once said, when I sit down to meditate, the very stones themselves shout to distract me. So in addiction, what is addiction in practice? The practice of distraction from an internal process that you don't feel comfortable with. So addiction recovery involves paying deeper attention and letting go to things that are not useful. And that means being willing to sit through boredom. Americans are really scared of boredom and silence. Like it feels weird to have a period of silence longer than 5 seconds. Especially on television. crew doesn't like dead air. But the idea is, who is it that's getting bored? Who is it that's distracting you from simply sitting and focusing inward? I mean, the meditation is just 11 minutes. That's nothing. Yeah. Who is it that's uncomfortable sitting with your old drinking buddy in silence? It's one of the things Tony said. Well, yeah, sitting with your old drinking buddy in silence and not drinking. What's uncomfortable about that? Oh, we got nothing to say. Maybe you could try for a deeper level of honesty. Oh, I don't want to cry. Okay. I don't want to cry on his shoulder. I'm no girl. All right, emotional expression. That's one of the things that you need to deal with. Who is it that justified smoking pot, and did you notice the rationale for smoking? It's better for you than the alcohol. Okay, so we'll be looking over, all these different little nuances within not only biopsychosocial recon, but also looking at pharmacology and basically the way out for people who have lost their way and use substances as a route to lose their way. So, what happens when your addiction is texting, the internet, the television, gambling? What do you switch to? Why don't you attend to the actual need that's driving your attention to those things? You notice these things are not actually fulfilling you? Can you sit and ask those questions? Because when you sit by yourself and you're bored, what you're saying is, I'm not interesting even to me. You check out whether that thought is real, because it probably isn't. More on this Tuesday. Have a good weekend. Hey.